We are here in our Boa PG lecture series. As all of you know, we take lectures now on Tuesdays and Thursday between 7 to 8 p.m. To kickstart the November month, we are starting with corneal topography as our first topic for this month. And to speak on the same, we have Dr. RUSHITA KAMDAR with us. She did her DNB from HV Desai Hospital, followed by her cornea and refractive with Dr. J.K. Reddy sir in Shankaraya Hospital, Coimbatore. Followed by that, she is working here in Mumbai as a cornea consultant in Ojas Eye Hospital. And she is very keen in PG teaching, and her topics of interest are corneal ectasia and topography and keratoplasty. And she will be taking us through the topography topic to make it easy, because topography now has become a language of cornea. Anything that you don't see on the slit lamp, topography is something that shows you all those hidden points. So Rushita will be taking us through the topography and make it simpler for even the first year MS and DNB students to identify what are the key points to read a topography. Rushita, thank you for accepting the our invitation, and it's over to you now.
Just give me a second.
Yeah.
Hi, everybody. Good evening to all the people who've joined in. Let's start the November postgraduate series with something that interests me a lot, and I'm sure that after this talk, it is going to interest you equally much. So I'm going to talk about corneal topography, start off with the basic topography, and then move on to a few advanced machines, and just also tell you how we can read these topographies with greater ease and also in much more detail, and we can actually understand what the topography tells us and what the cornea is trying to depict by the topography. So I hope my slides are visible and
Yes, they are very much visible.
okay. So firstly, why is topographic analysis so important? One, the main thing is that the corneal tear film air interface provides 2/3 of the versions of the eye. And it plays a very important role in the quality of optics of the eye. Hence, it is important that we analyze topography well enough. The indications for a topography, broad indications would be a keratorefractive screening, which is the most common indication. The second important indication is early identification of corneal ectatic disorders. This is a common indication we see in our OPD practice, especially people coming for a refractive error checkup. So when they have an against the rule astigmatism, say more than one diopter, or they have history of eye rubbing, or they have an oblique irregular astigmatism, it is important to advise a topographic analysis and also be able to read it well. Also, following corneal ectatic disorders like keratoconus or a PMD post C3R, post collagen cross linking, or post treatment, topography helps us a lot to see how stable the cornea is post any treatment of corneal ectatic disorders. It also helps us in surgical planning of cataract, because cataract surgery has become more of a refractive surgery these days. So it helps us in astigmatism management during cataract surgery. It helps us in the planning of premium intraocular lenses like the presbyopic IOLs, the toric IOLs. And it also helps us in getting through our patient expectations, because like I said, cataract surgery has become an extremely premium surgery and is almost like a refractive surgery. It also helps us to identify curvature abnormalities that limit visual acuity. So if there is a patient whose best corrected visual acuity is not improving beyond say 6 by 9, 6 by 12, and you are seeing a cylindrical value at an irregular axis, it is important that you do a topography and try and understand what is the curvatural changes or the contour changes of the cornea. So the aim of this presentation is going to be to provide an overview of current methodologies which are available for corneal contour evaluation. We'll provide some basic parameters for the interpretation of topography. We'll develop a step-by-step strategy for topographic evaluation so that by the end of it, everybody is able to analyze and tell us what is the treatment of that particular topographic image. These are the basic principles of topographers in today's times, and this is how we broadly categorize them. First is reflection based, wherein wherein we have the keratometry, the photokeratoscopy, that is the placido based topography basically. So it's a reflection of the placido rings from the anterior corneal surface. That is what is reflection based topography. The other one is projection based, which is by the raster stereography and laser interferometry. Another commonly used topographer is the OpScan, which is like a slit scanning based method of topography. We'll talk about this in detail later. The other is the OCT based, which uses the same principle like that in a normal OCT, which is the OptoView and the TOMI scan. Then you have Scheimpflug based, which is the gold standard topographers, which includes the Pentacam. And recently we've had the Galili and Sirius also, which are in the Scheimpflug based, but they have an addition of a Placido image also. And then you have a spot reflection based, which is the Cassini. So this is just a broad categorization of the topographers available these days. What you have to remember practically is the reflection based, which are more common, the Scheimpflug based, and the slit scanning based topographers, which we generally see images of even during the practical examination. Before I start off with the topography basics, I want you all to remember these few important points. First is that accurate analysis of the topography image depends on the quality of the scan. So it is very important that you see the quality parameters on the scan image. Always see them. Then the second point is that the abnormal topography can occur with any refraction, with any corneal thickness, and these should be first determined independently and then analyzed together with your clinical acumen also. Always, ectatic disorders are a bilateral disease process. So if you see a keratoconus in one eye, you must always ask for the topography image of the other eye if you are asked for any treatment or management based questions. Multiple devices are complementary and not interchangeable. What this means is that if at one visit, say pre C3R, you are seeing a patient's pentacam, and post C3R, you are seeing a patient's Sirius scan, you really cannot compare the two. And so it's just going to be a complementary image, but it's not interchangeable and exchangeable. Coming to the most common and the basic topographer, which is the Placido analysis. This basically reflects a series of rings of the anterior surface of the cornea. It gives us a pseudo color map by measuring the slope and the curve, and it computes the curvature of the cornea. So it actually just measures the slope and it computes the curvature. Hence, the Placido rings give us a pseudo color map. So the two most common devices in use have been the Keratron Scout and the NIDEC OPD scan, where OPD stands for optical path difference. This is the image of how the normal corneal mires look. As you can see, the corneal mires are circular, they are of uniform thickness, and the space between two corneal mires is also uniform. So this is like how, and they're very well centered. So this is how a normal corneal topography looks on the Placido ring map. Coming to how an abnormal topography on the Placido map would look. So this part, if you can see, it's like a totally irregular Placido based map. These mires are, they are farther apart, they are larger in diameter, and they are broader in width. So this is an area which is suggestive of a lower power. Lower power means a flatter keratometry or a flatter K reading. So low power mires will always be larger in diameter, they'll always be broader in width, and they'll be very widely separated as compared to higher power mires, which will be smaller in diameter, they'll be narrower in width, and they'll be very crowded. So this area is suggestive of a steeper area or a steeper cornea in the inferior part, and a flatter cornea in the superior part of the cornea. Now we'll just see how what are the different images that we could see in a placebo map. So this is a very normal cornea, which is like it's mostly green. That means it's mostly around 42 diopters. So it's a very uniform flat cornea. Then next, this is called this is called a symmetric bow tie showing with the rule astigmatism. So as you can see, there is a bow tie in the superior half, which is absolutely a mirror image of the bow in the inferior half. And both the bows are almost equal in their dioptric value. Hence, this is called a symmetric bow tie. Because the vertical axis is the steeper axis, so it's with the rule astigmatism. This is again a symmetric bow tie, but this is against the rule astigmatism. This is an asymmetric bow tie with a superior steepening. This is again an asymmetric bow tie with an inferior steepening. But what this image also shows is a skewed radial axis. So what does this mean? It is also known as SRAX, or skewed radial axis of astigmatism. So there is a skewing or an angulation between the axis of the two lobes of the bow tie. So this is one lobe and this is the second lobe. So these are the axes of lobe A and lobe B, and the angulation between them is known as the skewing angle, which is 25 degrees, and this is significant skewing in the axis of the superior and the inferior lobes, and hence this is suggestive of an ectatic disorder. This is again a localized inferior steepening with again skewing of the radial axis of astigmatism between the two lobes. This is a central steepening, so this is like a central keratoconus. And this is absolutely an irregular cornea. This is something that you might see after a keratoplasty procedure sometimes. Coming to another important thing when you are analyzing any scan on any machine for that matter, it is very important to check the steps and to check the range. Now you see these four images, they are all of the same patient, same eye, same machine. This actually tells us the importance of using and reading the grading scale and the steps in which the grading scale increases. So if you can see, this patient has a K value of 38.5 and 39.5. And what is happening between A, B, C, and D is the steps are increasing. So this is 0.25 steps. Step means the difference between any two colors on this scale. So this is 0.25, this is 0.5, this is 1 diopter, and this is 1.5 diopter. So there is a method, there is like a, we have this facility to actually change the step. So when the step is increasing, you see that the range is increasing. This is 35 to 41, whereas this becomes 30 to 67. So what happens is that if the steps are not adequately taken, then we can miss an inferior asymmetric bow tie in this, like in this patient. So probably if it was this or even this, we would have missed a subtle finding of an asymmetric bow tie with an inferior steepening. So it is very important that we check the range and we check the steps of the color scale before we analyze any scan on any machine. And we might miss this suspicious pattern, that's most important. So always check on your left the scale and the steps. Coming to two most basic things, what is axial map and what is curvatural map? So axial map is a more global indicator of the corneal shape. What it means is that every point on the cornea, the radius of curvature is determined by measuring the perpendicular path from the point of interest to this video keratographic axis. And this is basically a more global indication. It gives out a more averaged value of the entire corneal shape. Whereas the tangential or the curvatural map is the radius of an oscillating circle that is fitted to the point of interest. So this is not reference to the video keratographic axis. So it's like this is the tangential radius, and this basically this radius, the center of this circle from where the tangential radius is calculated is going to be different for every point on the cornea. So it is not subjective, or it is not in relation to this central video keratographic axis, which is stable. Hence, it shows the extremes, it shows subtle changes, and it is a more specific indicator of the curvature of the cornea at various points. So just to sum it up, axial radius is a more global indication, and it is in dependence with this video keratographic axis, whereas the tangential or the curvatural map is the radius of an oscillating circle which is fitted to this point of interest. So the radius changes, the center of this circle always changes, and hence it shows us a more specific picture, it gives us a more detailed picture, and we tend to pick up even subtle findings. Okay, coming to this, just the topography, this is a placido-based topographic image of a patient who was a 28-year-old female, and her central corneal thickness by the ultrasound pachymetry was 475 in the right, 480 in the left, and she had a stable refraction since last 5 years, which was as follows. This was in June 2009. And we followed her up. This shows like a curvatural map, shows a topography which is slightly steep in the center, as is seen by this orange color, which represents the 49-48 range. So it is steep in the center, which is a uniform steeping. Now what happens after few years is this steepening is exaggerated as an inferior steepening, and she had come to us for refractive surgery way back then, which we did not do because of the slight steepening that we noticed, and we observed her. And she finally landed up with this. So this is how important it is to follow up a patient who has got a thinner pachy also. She might progress into a keratoconus over a period of time. So it is important to maintain serial follow-ups of such patients. And the curvatural maps or the tangential maps are very sensitive to pick up such suspicious areas on the topography. This is another patient that I want you to also understand how the axial and the curvatural map looks. So this is an axial map which will give us a more rounded image, a more averaged out image. It will look more regular, whereas this is the curvatural map which will be a little irregular in shape because it will actually pick up the curvature of each and every point. So this is a keratoconus patient. This is pre-operative picture, and this is a post-operative picture of the same patient. Again, this is another patient. Okay, so is there anybody who can mute and unmute themselves and tell me what procedure we could have done? So the top two images are the pre-operative images, and the bottom two images are the post-operative images. Would somebody like to tell me what procedure could have been done for this patient? This is a patient of keratoconus. As you can see, there is localized steepening here. And this is a curvatural map of this patient's left eye, and this is the actual map of the patient's left eye, whereas this is a post-operative procedure. So could somebody, Sumit, any of your
Yeah,
residents, would they like to unmute themselves and tell me what procedure could have
anyone
been
can
done?
unmute or they can type in a chat box also. Even that is fine if you are not.
Yeah.
Yeah. So please type the answer. I hope you don't need any options for that. To treat a keratoconus, there are hardly 3-4 options available, especially
Which
treating the
form of
front.
treatment do you all feel could have been done in this
So
patient?
Vinit Shah is asking and telling it's intact.
Yes, that is good, Vineet. It is intact, of course. And that's because this is the area of flattening which has been induced by the intact ring placed inferiorly. This was like a 160-degree ring segment that we had placed inferiorly. So you can see that the cone is pushed more centrally, and that improved the best corrected visual acuity of the patient. So well done. Okay.
Rushita is going to send a gift to you, Vinith.
Sure, sir. So this is another patient. This is a special index which is available with this Keratron machine, which is known as the CLMI, or the cone longitude magnitude index. So this actually tells us the most steepest point on the cornea, and that is analyzed in relation to the entire cornea, and it gives us an analysis of this. So for laymen, it is very easy to understand that after this procedure of, we had done a C3R and a PTK, that is phototherapeutic keratectomy, and how the patient's cone has actually reduced in size and area, and so the patient's vision, even uncorrected vision, actually improved. So this is an excellent index which is available with the Keratron Opticon Scout. Now coming to, I told you all that how topography can help us to plan for premium IOLs. This is an important indication. Now this was a patient who came to us asking for a prelex, basically to undergo a multifocal lens surgery. This was his topography. These were his keratometry readings on the IOL master. And Technis multifocal, according to the A constant, the power was coming to 20 diopters. But what is important to know is that this is a very irregular topography that you wouldn't see in a normal patient. So we went back to the slit lamp and we checked. So the patient had dry eyes with some amount of mebomitis. So we gave the patient topical soft steroids, and we also gave the patient cyclosporin. With that, the patient's topography became more regular. The patient's K-metry also regularized and changed, and the actual IOL power of the patient was 21 diopters. And if we had implanted a 20 diopter lens, he would have landed up in a hyperopic error, which he would have been extremely unhappy with. So an irregular topography can tell you so much and actually save you from a refractive surprise post-operatively. So even the smallest of changes can be picked up with a simple device such as a placido-based image, and you can actually benefit your patients immensely, even your cataract patients. But there are a few limitations of these placido-based systems, that it does not analyze the posterior surface of the cornea. It does not give us any corneal thickness data. There is limited data for scarred corneas, and the corneal coverage is just limited to 8 to 9 mm. So it kind of neglects the periphery. So sometimes could miss something known as a PMD or a Terriens, and there could be a high incidence of false positive. I'll tell you what is false positive. So the next generation has come over and taken over these placido-based devices, which includes the OpScan, which includes Pentacam, which includes the Visante OCT, and the TMS5, the Galili, and the Sirius. Coming to the first, which is the OpScan 2. This is a device which has been there at a lot of institutes across the country. And it is basically a combination of the placido-based scanning along with scanning slit. So what does scanning slit mean? It is basically an elevation-based method to detect the contour of the cornea. In this orb scan, there are 40 slits, 20 from the nasal side and 20 from the temporal side, which is projected on the cornea to assess 240 points on each slit. And this triangulation between the reference and the reflected beam captured by the camera can be used to analyze the anterior and posterior corneal curvature and the pachymetry. So it is important to remember one thing with the orb scan is it does not give a true analysis of the posterior surface, but it calculates the pachymetry. So it calculates the contour of the anterior surface and it accurately calculates the pachymetry at each point. And by the subtraction between these two, it gives us a calculated and a computed analysis of the posterior corneal surface. So this is a small disadvantage of the scanning slit based elevation topography over the sheen flux based methods. Let's talk about what do you mean by elevation based methods. It's a little basic, but I thought I should cover it. So an elevation based method will always have a reference, like we have a reference of sea level. So this is point 0, and anything above it is going to be plus, or anterior to it is going to be plus. It's going to be a higher point, a more elevated point. Anything below this is going to be in minus. Anything posterior to this is going to be minus. And posterior is represented by cooler colors. It's a lower down point and it's a depressed point. So how is it represented on our machines? So the blue area that you can see is our cornea that we are imaging. Sorry, the yellow area that you can see, the yellow line that you can see is the cornea that we are imaging. The machine calculates this blue semicircle that you can see, which is known as the best fit sphere. Now, the prolateness of a cornea normally causes the center, that is this yellow line, is gone above our elevation best fit sphere. This results in a central hill. And this central hill is depicted by this elevation or red area in the center. This is how a normal prolate cornea would look. Now, if you see the mid periphery, this is the cornea that we're imaging falls below the reference sphere. Hence, we see a peripheral shallow area or a peripheral gutter, which is known as an annular C, and this dips below the reference surface. Again, at the extreme periphery, the prolate cornea slightly is elevated above the reference surface, and so we see these hot colors in the extreme periphery of an image. So this is how an elevation based topography for a normal prolate cornea looks. We have the central hill because it rises above the elevation based best fit sphere, surrounding which we have a depressed area, which is our periphery, and the extreme periphery is again hot. So these maps actually display how elevation represents a prolate cornea. Coming to how an astigmatic cornea would look on an elevation based profile. So again, we have the flat axis and the steeper axis. So the blue one is the flat axis and the pink one is the steeper axis. So we have two meridians which are at 90 degrees apart. The sharp or the steep profile is going to fall below the corneal surface, and so it will be represented as cooler colors, and the flatter profile is going to rise above the corneal surface, and hence it will be represented as warmer colors, and the resulting topography is known as a central saddle. Now, even based on this topography of a central saddle, we can actually know what is the degree of astigmatism of the patient. So a larger astigmatism is going to show a greater difference between the points on their principal meridians. So this is showing purple and this is showing red. So there is a greater difference between the steepest and the flattest meridians, and hence this patient has a higher astigmatism, a larger astigmatism than this patient. So topography actually tells you so much about just the cornea. Coming to corneal thickness. Now in corneal thickness, it's a little opposite, that red is thinner and blue is thicker. So don't get confused. Coming to this image of the orb scan, and what I would like to ask everybody here is, I hope you can see, you all can just write it in the chat box. My question is that can we go ahead with refractive surgery for this patient?
The question is, can you go ahead with the refractive surgery here? If you cannot see, you can see as the keratometric value as 46.3 and 45.8. And
if you all want any additional data, let me know.
yeah, and the pachymetry is also written over here as 533 microns. So with this minimal information, would you go ahead with the surgery? Anyone, even yes or no is fine. So we can go ahead. So Juhi
So
says
I'll
yes.
just tell you all how to, how in your practical exams you must actually give the answer is that this is a quad map analysis of a patient and of the patient's right eye. And this is the anterior float. What does it show? It shows a normal prolate cornea. This is the posterior float, which also shows a normal prolate cornea. This is the pachymetry map, which shows the central pachymetry to be
Ruchita, sorry
around
to interrupt.
540.
Your pointer is not seen. Your pointer
Okay,
is not.
sorry. Why is it not seen? Okay, so this is it's called a quad map analysis of the patient's right eye, and we have got 4 maps on the OpScan: the anterior float, the posterior float, the keratometric curvatural map, and the thickness map. So these two are showing normal annular saddle pattern that I showed you. Sorry, it's showing the annular map pattern with the central steepening that I show you. This is called a central island pattern. And the central pachymetry is around 540, and the curvatural map is also showing normal corneal readings. So now at least tell me as to if anybody knows the answer whether we should go ahead with refractive surgery, that I would send the patient to your to do refractive surgery. Has anybody answered? Sumit?
Yeah. So both Juhi and Miti both have answered as yes.
Okay, so great. So you already have a lot of refractive surgeons in your postgraduates. Good, you're inspiring them. Okay, now coming to this image, this is again a quad map analysis of another patient. Is the slide values clear? Now, what I want to show you on this is that there are certain red flag signs on keratoconus that we must see on an op scan. The first is the posterior best fit sphere here. So if this posterior best fit sphere that you can see is more than 55 diopters, it could be a keratoconus suspect. If the irregularity in the 3 millimeter zone is more than 1.5 diopters, it could be a keratoconus suspect, which it is over here. And if the irregularity in the 5 zone is more than 2.5, it is a patient could be a keratoconus suspect. Apart from this, of course, the central pachymetry is less than 470, which is another red flag sign for keratoconus. And all these factors you must take in consideration to diagnose the patient as a keratoconus patient. Coming to the next more common gold standard devices, which are based on the principle known as Scheme-Flug principle. This is very important. It is a theory question and a practical question both. What does the Scheme-Flug principle say? Now, in this, in the first image to my extreme left, here you can see that the subject plane, the lens plane, and the image plane, they all are parallel to each other. Hence, we have a very sharp image, and the quality of the image is excellent. But what happens when our image is a curved surface like the cornea? So every time the subject plane is not going to be parallel to the image plane, and hence we'll have a poor focus at the periphery of, so the image quality is going to be bad at the periphery. It might be better at the center, but that's not what we want. We want to analyze the entire cornea as clearly as possible. So came the Scheme-Flug principle, and this is the point of Scheme-Flug intersection. So the subject plane is still not parallel to the image plane. However, the image plane is manipulated according to Scheme-Flug principle so that there is a point of intersection between all these 3 planes, the lens plane, the image plane, and the subject plane, and they meet at this point of Scheme-Flug intersection to give us a focused image both in the center and the periphery. So basically the lens is tilted so that the object and the image are much more in focus as compared to how it would be here. So this is very important, is the Scheme-Flug principle. You should also know how to draw this because they ask this in theory also, and the diagrams are important. So coming to the pentacam, the pentacam device includes 2 cameras. One is in the center, as you can see here. So one image is in the center. This is one blue arrow is pointing to one camera, and the other camera is on the side, and that's the sheen flag one, which is mounted, and this rotates actually. And this is on a rotating wheel for capturing slit images. So it allows the center also of the cornea to be measured precisely. Now the sheen flag image analyzes a lot of things very well. It gives us a 3D analysis of the anterior chamber. It measures the pupil size. It gives us a pachymetry map. It gives us topography maps, both anterior and posterior, along with elevation maps of anterior and posterior cornea. It gives us a 3D cataract analyzer. It gives us a 3D image of the posterior IOL simulation also. It gives us something known as the Bellin-Ambrosio enhanced ectasia, which we'll discuss. It gives us the holiday report for cataract patients. And the data points are also captured from the center of the cornea, which is missed in placebo-based images. And because it is independent of any axis or orientation or position, it gives us a more accurate representation of the true corneal shape. Coming to what all you should see in an pentacam image, before the image, we'll just discuss these few parameters that you should know. Like I told you, you must always see the quality specification, which is in this box on the extreme left. You see QS, that is quality specification. Then you see something known as the Q value. What does Q value mean? Is asphericity of the anterior surface of the cornea, and it is measured within the central 6 mm. Normally, it is -1 to 0. And in myopic LASIK, post-myopic LASIK, we'll get an oblate cornea. So that time it will be positive. Otherwise, in normal corneas, it will always be -1 to 0. Then we'll have a flat K and a steep K reading. And we'll also have the astigmatism readings. And what you can also actually eventually determine from these readings is how much myopic LASIK or how much hyperopic LASIK the patient might have undergone. Then it will tell you the pupil, the pachy at the center of the pupil, and it will give you the coordinates of the thinnest point also, which is another red flag sign for diagnosing keratoconus. Another important value is the Kmax. Kmax is the maximum K reading on the anterior surface of the cornea with the XY coordinates in these two boxes. It will give us the anterior chamber depth. It will give us the pupil diameter, and it also gives us the white to white, which I don't think we can see in this image. Okay, so now let's go to a few images of the pentacam. One second. All right, so this is a patient a normal best corrected visual acuity and normal slit lamp findings. And what can somebody point out from this pentacam image? Would somebody like to tell how we would speak out this map? Or what is the abnormality seen in this? The patient had normal best corrected visual acuity and normal slit lamp findings.
You can type, or somebody wants to describe can request to unmute. I can unmute them also. That is totally okay. We can make it more interactive. If any one of you wants to unmute, you can just put.
Yeah, so let's make it more interactive so that I also know what y'all have understood and what y'all want to know more. I have a lot of images. So accordingly, would somebody like to tell, or should I only?
No, devising the central cornea thickness is reduced.
Yeah, correct. What else? That's great. You have recognized this point of corneal thinning where the cornea is around 480. All right, great. And something else?
Anything else, Divya? Or
something else in this map? So you got to look out for something known as posterior keratoconus. So posterior keratoconus is a condition where only the posterior cornea is going to show this area of elevation, which you can see as +26 over here. So the posterior cornea actually accounts for only 7% of the overall refractive power, and hence the patient had a normal best corrected visual acuity. But this point of corneal thinning is actually coinciding with this point of posterior corneal elevation, posterior corneal steepness, and this is something known as posterior keratoconus, which you all should look out for in any shame flux based or scanning slit image that you all are given. Okay, so coming to the other things about the Pentacam, which is the Bellin Ambrosio enhanced ectasia display. Let's talk about this. All right. So let's talk about something known as the enhanced best fit sphere, which is important for us to understand what is the Bellin Ambrosio enhanced ectasia display. Now, this is a patient's cornea who has a keratoconus. The blue image is the patient's cornea, and the yellow one is the best fit sphere. Now, the red arrow that you can see going above is the elevation that is going to be recorded on the elevation map. This is with a normal best fit sphere, whereas this is the new reference sphere, the red one. And look at the difference in the amount of elevation that you see between image A and image B. So what happens is that with a new reference sphere, or what is known as an enhanced best fit sphere, when calculating the best fit sphere, they exclude the central 3 mm of the cornea. And because they exclude the central 3 mm of the cornea, which is the most steep part, so you get a corneal best fit sphere, which is a more averaged out best fit sphere. And so it is more sensitive to pick up a keratoconic or an elevated point rather than a normal best fit sphere, which takes into account the entire cornea. So that is the difference between the two, and we'll see how that matters. So this is the image of the patient, the back surface of the elevation of the patient with a normal best fit sphere, because it takes into account both the central 3 mm keratoconic area and the peripheral also. So the maximum elevation that we are seeing is hardly in plus 19 microns. Whereas if we exclude, here you can see there's a small option where we exclude the center. So we exclude the central 3 millimeter and then we calculate the elevation readings, and that's when we get it as 38. So this is a more sensitive way of picking up the elevation from the patient's cornea, and we do not miss even subtle findings, even subtle elevation. So again, this shows the same, that this is the best fit sphere, the first one, and this is the enhanced best fit sphere. As you can see, it is written in small that it excludes the central 3 mm. So the elevation points are more exaggerated and we tend not to miss anything. And this is actually the difference between the above two best fit sphere. So this we'll just miss. So I'll just ask you all this question, that which screening metric is the most important out of these four? So you can write it down in the chat box. Sumit, what is the answer?
It's screening.
A is Bellin Ambrosio enhanced ectasia display. B is ocular response analyzer keratoconic match indices. 3 is subjective scan image evaluation. And 4 is documented scanning slit and placido parameters.
Julie answers here as a bad display. None of anyone else want to
Anybody
try?
else? It's not
Again,
bad
one
display.
more time.
That's not the most important thing. Anybody else? Okay, so basically it is a subjective scan image evaluation. You're supposed to evaluate every scan with more detail, and that is going to allow you to pick up sensitive findings just by looking at a Bellin-Ambrosio enhanced display. Though it looks the more sketchiest option, that's not how you're going to actually be able to analyze. Sumit, do we have time to go on with the series? Or is that too advanced
Yeah,
for them?
we do have 10-15 minutes more, so no problem. You can go ahead.
So I think rather than the series, I'll just tell thickness map.
Yeah, that's better. Yeah.
And we'll just discuss a few more topographies. So these are few interesting things that actually y'all could see. Now, what can you all hear me?
Yes, yes, yes.
Okay. So what I want to tell you is that there is an index known as the progression index, which is mentioned on the Bellin-Ambrosio enhanced display map over here. Now, this is progression index actually stands simply for thickness upon the location relationship. So it gives you the pachymetry analysis depending on the location of the cornea. So normally this value of the progression index over here is less than 1.1. And the progression index basically represents what is the rapid change of thickness from the thinnest location to the corneal periphery. So the higher the progression, the higher the index, and vice versa. So high index more than 1.1 is going to be a suspicious cornea. So, and it's a very, very sensitive index. So you all must also look at this progression index along with these 6 images that I explained to you about when you're analyzing the Bellin-Ambrosio enhanced ectasia maps. Now, coming to this, this is showing us, so there are 2 more maps that you see here, which is called the corneal thickness spatial profile and the percentage thickness increase. So what this shows us is that the pachymetric progression index shows us, one second, sorry. Where did that go? Yeah, so this is the corneal thickness spatial profile, which actually measures the average thickness along these 22 circles that we see. And they are in increasing diameters of 0.4 millimeter steps. And the percentage thickness increase is the percentage increase in the thickness of the pachymetry at those same 22 points. So this is what those 2 maps show us. So this is a map of the cornea, and here this is the central one is like actually the mean reading, and the above and below dotted 2 lines are plus minus 2 standard deviations from the mean. So whenever this red line is parallel to the central line and lying between the above and below dotted lines, that means it's a normal cornea. But if this is not parallel to the middle line, or if it dips way before 6 millimeters, that is an abnormal cornea, and that is to be taken as a red flag sign. Similarly, for this percentage thickness increase, it is absolutely lying outside the 2 standard deviation, and hence it is to be taken as a red flag sign. So keratoconic corneas had a much higher percentage increase at each diameter centered on the thinnest point. Now, an interesting thing that I want to tell you is this case. I don't know if you all can see the pachymetry. The pachymetry is actually 600 plus. And this corneal curve, we've always seen either normal curves which are parallel to these 2 lines, or we've seen curves that dip more. So they're more angulated. But what about curves that are flattened like this? What do you think they represent? I mean, this is an absolute, it's a very difficult question, but if anybody of y'all can answer, and y'all can also see these reflectance images, and I'll actually tell y'all what this means. But do y'all want to take a guess what it means? I mean, this is, I mean, I would give like plus 100 to whoever could answer this question. But what I want to tell you is, one is the pachymetry 600 plus, and the keratocone, this percentage thickness corneal curve that we see is flattened out. So you should know one thing, that this is not an ectasia that we're talking about. The other thing is that you see there is increased reflectance of the iris structure. So this is a Scheimpflug image where this is a normal patient's cornea, this is the iris, and this is the lens. So in the right hand side, you are seeing that there is increased reflectance of the iris structures. So what do you think it is? Has anybody answered?
Corneal edema, that's what Julie.
Yes, great. So why do you think, what is the etiology of the corneal edema? Definitely corneal edema is correct. That's good. So it's basically flattened out curve with increased reflectance from the corneal guttae, as in a case of Fuchs endothelial dystrophy, which has resulted in corneal edema. So this sometimes also helps us to pick up the guttae that we might have missed on slit lamp examination. Okay, now one more last question is that what is the most important element to identify on any screening map? Curvatural pattern, corneal thickness, image color steps, or pattern recognition of specific abnormal patterns? What is the single most important element that you all would say?
Anyone? You just have to type the answer. We have discussed all these 4 patterns. So it's option 3. Few people are saying option 3, few people option 4.
So option 4 is the correct option. So the most important element is pattern recognition of specific abnormal patterns. Of course, option 3 is also correct, but 1 out of 4 has to be right and the second one will be just correct. Okay. So this is again another patient's corneal topography that I would like to show you. And this patient also had a normal best corrected visual acuity. And here you could see that the OD, that is the right eye, is showing inferior steepening with asymmetric bow tie, and the left eye almost looks normal. But I told you all one thing, that ectatic disorders are usually bilateral. And so we went ahead and did a pentacam. This is the right eye of the patient, shows an elevated area on the enhanced ectasia display. The corneal thickness spatial profile again shows curves which are deviating way before 6 millimeter. So in this corneal thickness spatial profile, it is very important to observe the contour of the cornea and to also observe where the curve is dipping down. So if the curve dips down before the 6 millimeter point, that is considered as abnormal. And here, of course, the percentage thickness increase curve lies outside the normal range. So the right eye is definitely keratoconus, but in the left eye also, we are seeing that there is an area of elevation in the enhanced ectasia best fit sphere, and plus the percentage thickness increase curve is out of the normal range, which tells us that always remember ectatic disorders are bilateral, and always in your exams ask for the image of the, or ask for the scan, or ask that you would look at the scan of the left eye also. This will get you brownie points for sure. So I think Sumit, we will conclude, and if they have any questions, because the rest of the slides are on serious, which might get more advanced for these students. So if you all have any questions, or if you all would like me to tell you about anything in particular, I do have a few more scans that we could discuss. But if you all want me to just tell you about something more, or if you would like to see any scans of a particular machine, then you all tell me. So accordingly, I will just show you in the next 5 minutes or so, and then we'll wrap up. Any questions that you all would like to ask?
So I have got one question here on my chat. Is the topography done on the Placido and Scheimpflug are comparable to each other or not?
So Scheimpflug is, like I told you, it's an elevation based method where the entire cornea is analyzed, including the center of the cornea. It's a more accurate method rather than Placido, because it does not have any reference axis as just it does not have any reference axis by which it measures the curvature at any point. It does not miss any point in the center of the cornea, which a Placido based image would miss, because there is no ring in the central 3 mm with a Placido based topographer. So a Scheimpflug image is way more better and gives us much more detail than a Placido based image. There is no such comparison between the two. But they both have their own specialities, I would say. Like a placido doesn't have a posterior analysis, it wouldn't measure the central 3 mm, and whereas the Shimflag would do all of this. Yes, next question.
Okay, there's one more question: how to approach a topography from a practical point of view?
Yeah, okay, so I'll
Uh,
just tell you this question.
I think they want to know how to
Yeah, all right,
read it.
okay, I will tell them. So let's take this topography. This is
Some quad
I'll
map
show you a
image.
pentacam, 1 second, a quad map. So we'll just take this quad map analysis of this patient. So what you have to say is that this is a quad map analysis of patient XYZ of the left eye of the patient. Then you come to the quality indicators of the scan. So QS stands for, this is most important to see before you say anything. So the quality of the scan is okay. That is good. That is the first thing that you should say. Then you must go to the keratometry values. So this is the front cornea details and this is the back cornea details. And so the flat cornea, the K1 is the flat cornea, which is 41.9 diopters for the anterior surface of the cornea. And the steep is at 45 degrees for the front surface of the cornea. Therefore, the astigmatism of the front surface of the cornea is 3.2 diopters. Now coming to the steep axis. So this 45 degrees, the steep axis is always shown over here, and this is 87.3 degrees. So this is what you should always remember, that 45 degrees is the steep axis, and that is at 87.3. Coming to the eggshell or the front curvature of the cornea. So this shows a central asymmetric bow tie with a minimal inferior steepening in the eggshell or the sagittal curvature of the anterior surface of the cornea. Coming to the back of the cornea, again we have a flat K and a steep K and the axis and the astigmatism of the cornea, and we go about it in the same way. Coming to the elevation maps, you must describe both of these elevation maps together. And what you must describe is that this elevation map is showing the saddle pattern that I had told you earlier. So this is called the saddle pattern. That means this cornea has an astigmatism, inherent astigmatism. That is when you see a saddle shaped cornea. So you have this as one axis and this as the other axis. And that is the reason you see this sort of a typical saddle pattern, which is represented in both the front elevation map and the back elevation map. Coming to the corneal thick, and then you also, of course, talk about the maximum elevation that you see. So here the maximum elevation is 12 microns, and in the posterior surface, the maximum elevation is 21 microns. So the rule is, the red flag sign is that in the front elevation map, if the elevation is more than 12 to 15 microns, it is a red flag sign. And in the posterior map, if the elevation is more than 18 to 21 microns, it's a red flag sign. And coming to the pachymetric map, this is the thinnest point on the cornea, which is at 542 microns. So if you see, and these three maps, the point of maximum elevation on the front surface is coinciding with the point of maximum elevation on the back surface, which is coinciding with the thinnest point of the cornea. And hence this could be a form fruste keratoconus or a keratoconus suspect that I would like to evaluate clinically. This is how you describe it. So this, the other things that you could say is the internal chamber depth, internal anterior chamber depth, which means the anterior chamber depth from the endothelium to the anterior lens surface is represented as 3.39 millimeters. This you can see diameter cornea. This is not shown here, but this is actually the white to white, which is an important parameter for measuring the sizing of the ICLs, that is the phakic IOLs that we use for higher powers where LASIK is not possible. This is the lens thickness, and this it gives us the corrected IOP according to the thickness of the cornea. Then you have the front Kmax, which is also an important thing. So 47.6, that also you should mention. And the thinnest location is also shown here. So the coordinates are also important. So if it is more than 1 millimeter or 0.9 millimeter away from the center, that is again a red flag sign that you must talk about. So basically, when you see anything, when you're given any image to analyze, just keep talking about all the stuff that you can see, and then only ask the examiner to question you, because if you've said most of the stuff, then they usually do not ask you any other question.
Okay.
Anything else that you
Yeah,
would like me to tell you?
there is one more question, like how do you identify a post-refractive cornea on topography? And is it possible to know that which refractive surgery has been performed?
Yes, sure, I will show you this. Okay, so I don't think I have it, but what I can tell you is that
Yeah,
in a post myopic refractive surgery, the central cornea is going to be flattened. So on this quad map analysis that I showed you here, this part over here is going to be blue. It's going to be the cooler colors in the center if we do a myopic LASIK. So if the patient had say a -5, for example, this central cornea is going to be flatter as compared to the peripheral cornea. And there is actually also an algorithm on how we decide how much myopia has been corrected. So the approximate way is that for every diopter of myopia, around 0.75 diopters of flattening happens in the keratometry value. So for example, if the myopia was of -5, and if we consider that the patient's keratometry readings pre-LASIK was say around 44 diopters, then post LASIK that 44 would have probably reduced by 0.75 into 5. So that would be around 3.5 diopters. So it would have become around 41.5. So this central flattening is what shows us myopic LASIK. And the other thing is that you will see even in the corneal thickness map, there will be a regular uniform central flattening. Whereas for an hyperopic LASIK, it is going to be exactly the opposite. What happens in a hyperopic LASIK is that the LASIK takes place in the mid periphery, and that's how the power is corrected. So there is a relative steepening of this central cornea, and that is what represents a hyperopic LASIK. So actually it looks like a central steepening, but you must never confuse it with a keratoconus, because in a keratoconus you will have somewhere you will have a very thin pachy, whereas in a hyperopic LASIK the pachymetry is going to be always uniform all throughout. Only in this keratometric map you will see a central steepening in approximately the 7 mm zone. That's how you differentiate between the two. And the similar criteria for hyperopic LASIK is that there's going to be a steepening in the keratometry by around 1 to 1.2 diopters for every diopter of hyperopic LASIK that you perform. So this is the other way that you can actually calculate the amount of hyperopia that has been corrected.
Okay. So basically, you need to look for the center part of the topography, 6.6 to 6.5 millimeter. Look for flattening. It will be some cornea of 37, 38 diopters, and the thinning will be around 450, 440 microns. So you will understand that such a regular topography pattern is basically iatrogenic created in the refractive surgery. Based on the flattening or the steepening, you can guess that it is myopic LASIK or hypermetropic
Okay,
LASIK.
Sumit, just give me a second. I will share it. Let me just share it with you.
Yeah.
I can share the. One second. I can just show them pictures.
Screen is locked, I suppose. Rushita?
Yes, 1 second.
Yeah.
What happened?
Yeah, I think your screen is locked. We can just see the same thing like PowerPoint.
Screen is what?
Locked, like it's. Are you trying to change the slide or something else?
Yeah, I'm trying to show them the post myopic and post hyperopic. You all can't see?
No, no, nothing we are able to see. Only the slide which is going on that is stuck somewhere.
Okay, 1 second.
You might have to stop sharing and share again.
Okay, okay. Can you share? Okay, I will. Now, can you see my screen?
No,
Now, can you see?
it's the same screen basically. Your PowerPoint presentation going on. It is minimized in the presenter mode. Now we can see that.
What can you see?
Now we can
The
see you.
topography.
No, no, no. Now we can see you. Your screen,
All
screen.
right.
Yeah.
So, see, now you can see the
Yeah.
image of
Now
the
we
patient.
can see the image.
Okay, so this is the topography image that you all would see post a myopic LASIK. And like you can see in the center, this is the zone of ablation that we've done. And the corneal curvature is around 40 diopters. And this is a symmetrical flattening in the center that we've achieved with LASIK. And what you have to again say the same thing, that the flat case 40, steep case 41 at 33, and this is the astigmatism of the patient that is shown by the topography. And the pachymetry is like you can see around 400. So this is how a post myopic LASIK image on the topography would show. So basically the central area of corneal flattening is the most important thing that you're supposed to recognize, and the other thing is correlated with the pachymetry. Now I'll show you how a hyperopic LASIK looks.
Screen is not shared yet.
Yes, I'll share it. Now it's shared.
Yeah.
Yeah, so this is how a hyperopic LASIK looks. Like I told you, it is similar to a central steepening of the keratoconus, but it is way more regular and you're supposed to correlate it with the pachymetry. So like you can see, the flat K will be around 46 and the steep K will be around 47. So it'll be way above 45, both the flat and the steep K. And it'll be a more regular reading. Like suppose if this was a keratoconus, one would have been say 42 and the other would have been 48, but these two will be very close to each other and there'll be hardly any astigmatism. And this is how the central zone of steepening looks, followed by this mid peripheral area of flattening, which is where we actually carry out the excimer laser to correct a hyperopic power.
Yes.
All right. Anything else that I could?
No, I think we have answered everything they asked till now. And
ठीक है. All right.
thank you, Rushita, and thank you everyone for attending. And thank you, Sapnesh sir and Preetham sir.
All right.
We'll conclude
Thank
the
you,
lecture at
Sumit, and
2:30.
thank you, Dr. Swapnesh, sir, for giving me this opportunity to get back to all the PGs. And if you all have any doubts or if you all want me to share with you any topographic images of any machine, do let me know. My email address is rushitakamdar@gmail.com. and I will definitely share with you whatever images I have. And maybe before before your practical exams, I could just show you all a few images of the different machines that we are generally asked. It's a very basic thing that you all are asked in the exams, and you just have to keep on talking that whatever I told you all and whatever is written on the map, and so that the examiner knows that you know enough, so that they usually don't ask you any more questions. And then they go on to management. How will you manage, and what will you do next for this patient?
Thank you, Rushita. Good night, everyone.
Thanks. Bye.